Like for instance, let me just ask you. If I were to ask you right now, do you remember or what could you tell me about thyroid emergencies? What could you just say off the top?
No idea.
Okay.
I really
Okay.
struggle with
So
retaining that.
the way you want to think about endocrine emergencies for and this is for everybody. The way you want to think about endocrine things is either things are speeding up or things are slowing down. So let's say we're talking about the thyroid. So last week I talked about the hormones. Kayla, do you remember the hormones? You were there last week. What are the hormones that go up in, let's say, hyperthyroidism? Unmute for me.
Um, if I remember, I think I'm getting my terms mixed up, but is it the T3 and the
It
T4? No,
is,
that's
right. So in
okay.
hyperthyroidism, T3, T4 go up, and then what hormone goes down?
The
All right, so let's go over this
hypo.
quickly. So that's okay. We'll just go ahead and tackle this now. So in hyperthyroidism, all right, so the hormone that's going up is we have an increase in T3 and T4, and therefore the
Mhm.
hormone that goes down is thyroid stimulating hormone, so TSH. Okay. Now, or we can have hypothyroidism, and that's where your T3, T4 are going down, and conversely, your TSH is going up. So notice that. Let's draw it out kind of how it is. So here's our brain. Okay. And in the brain, remember I said last week, we have, okay, so this first thing, you don't have to know all of this. I'm just kind of orienting you to where structures are located in the brain. So this first structure that I just drew, okay, this is the cingulate gyrus. Then we have the corpus callosum. All right. So the corpus callosum, that's the part in the middle of the head that separates the left hemisphere from the right hemisphere. That's the matter in between that allows the signals to go from one side of the head to the other side of the head. That's called the corpus callosum. So that's what I'm highlighting right now. And then under the corpus callosum, so we have, for instance, we have the thalamus, we have the hypothalamus, and then we have the pituitary. Okay, so if this is the posterior part or the back of the head, and this is the anterior or the front of the head, the pituitary has an anterior and a posterior part. Okay, so we have an anterior and a posterior pituitary. Now here, let's highlight this. Let's put this part in green. So right here in the pituitary, that's the master gland that controls all the hormones. Well, for instance, here in the pituitary, it sends a signal to, let's say, your thyroid. And so last week I said, remember that the thyroid is sitting in front of the trachea. So let's put a thyroid in. So it's kind of this butterfly shaped gland that sits in front of the trachea. So anterior to the trachea. And so it produces something called TSH. Okay. And then it also produces T3, T4. So what happens here, in fact, let's put TSH, let's put it more being controlled by the pituitary and T3, T4 primarily with the thyroid. So what happens is when the thyroid is releasing a lot of this, it sends a signal back here to say, all right, calm down the TSH. So when we have too much of this, we don't need as much of this. Okay. But when we have a little amount of this, then we need more of this. So there's what's called negative feedback. As one goes up, the other goes down. As one goes down, the other goes up. Does that make sense? That part so far, Becca? Okay, so now let's talk about the hyperthyroid situation. In hyperthyroid, some common situations that could cause it would be things like it could be Graves' disease. So that's an autoimmune condition. You could have medications or drugs, drugs or meds that could cause your thyroid to be overactive. Now, some symptoms that you're going to have is you want to think of everything being increased. So we have an increase in heart rate, we have an increase in blood pressure, we have an increase in metabolism, we have an increase in temperature. Okay, we have an increase in GI motility. So what does all this actually mean? Okay, increased heart rate, so that's tachycardia. Increased blood pressure is probably going to cause them to be hypertensive. So they're tachycardic, they're hypertensive, they're tachypnic, their breathing rate is faster due to a higher metabolism. Also, if your metabolism is higher, you're going to be losing weight, so they're going to be skinny, so they'll have weight loss. If they have an increase in GI motility, the gut is more active, so now they're going to have things like diarrhea. Increased temperature, they're probably likely to have a fever, or they have what's called a heat intolerance. So everybody else is comfortable in the room, but they're hot. Okay, just think of everything being ramped up in hyperthyroid. The dangerous part of this, or the most life-threatening form of this, would be a thyroid storm. Okay, so thyroid storm. Think of a storm. It's going crazy. What you want to know here is because in a thyroid storm, you have a dangerously high heart rate, you have a dangerously high blood pressure, for instance. So this dangerously high heart rate can put you into things like VTAC, okay? Or this dangerously high blood pressure can cause you to have a stroke, can cause you to have a heart attack, can cause you to have a hypertensive crisis. So all of those are things that are life-threatening emergencies. So we've got a big treatment here. If somebody's in a thyroid storm, the way you're going to recognize it is everything is just going out of control, but especially heart rate is through the roof, blood pressure is through the roof, things like that. The biggest treatment here is going to be a beta blocker, and the drug of choice is the beta blocker known as propranolol. Okay, now if you don't have propranolol, you may not carry that in EMS. That is kind of the drug of choice for it, but if you don't have it, then another beta blocker based on what your protocols allow. Okay, so that's thyroid storm. That's where everything is ramped up. Let's talk about the opposite side of that. So now let's go over to hypothyroidism. Remember, so your T3, T4 levels are low, and therefore your TSH levels are high. In this case, all right, so in this case, some causes could be the autoimmune condition Hashimoto. So Hashimoto thyroiditis, okay? Who gets these kind of autoimmune conditions? Typically, it's going to be females greater than 40 years old. So greater than 40-year-old female, that's just kind of the prototype or the stereotypical person of who gets it. Anybody could get it, but what's an autoimmune condition? It's where your own body starts attacking itself. So in this case, your own body starts attacking your own thyroid. So it could be Hashimoto. It could be, let's say somebody has had surgery. Okay, so maybe their thyroid had to be taken out either due to a goiter. A goiter is an enlarged thyroid. Some people who get this would be people who have iodine deficiency. So iodine is in salts, or not all salts. There's iodized and non-iodized salts. So let's say somebody is on some kind of non-iodized salt. They never go out to restaurants where salt is added in the food. It's less likely that in the US somebody would have an iodine deficiency, but it could happen. But worldwide is where we see this more. But going back to the surgery, so somebody could have had some problem where maybe their thyroid was getting too big and it was starting to squeeze on their airway, and they had to take it out to keep the person alive. When you remove the thyroid, now you no longer have that thyroid hormone, and thyroid is something that we need to keep us alive. Like, for instance, we need cortisol. We also need thyroid hormone. Without it, you can't really stay alive. So somebody could have had it taken out. Now, when they've had it taken out, so whether they had a hemithyroidectomy or total thyroidectomy, they're going to be on meds for life, and they'll be on something like Synthroid, levothyroxine, okay? And they'll be on it for life. We mentioned all of this last week, by the way. Now, the dangerous form of this one, so first of all, let's talk about the symptoms. So in hyperthyroid, everything is kind of ramped up. In hypothyroid, things are kind of calmed down. So you're going to have a decrease in heart rate, a decrease in respiratory rate, a decrease in blood pressure. Instead of your metabolism being ramped up, your metabolism is going to be down. Instead of GI being up, you're going to have a decrease in GI motility. You'll have a decrease in temperature. Okay, now what does this mean practically? Decreased heart rate, so that's bradycardia. Decreased respiratory rate, bradypnea. Decreased blood pressure, hypotension. Decreased metabolism. Well, now if your metabolism is going down, that means you're packing on weight, so they're probably going to have weight gain. Decrease in GI means that stuff isn't moving through your gut, so now you're going to have constipation. Decreased temperature, you're probably going to be cold. While everybody else is comfortable, you're cold all the time. So think about a person, think about like a greater than 40-year-old female who's feeling sluggish and hypotensive and weak, gaining weight, having constipation, they're cold all the time. That's how those kind of symptoms would present. Now, just like everything, so the way I want you to think of it, everything is kind of like a continuum. So we're going to say this is low and this is high, okay? Well, let's say this part in the middle, that's where you have kind of a normal thyroid, or we call that euthyroid. Okay, so you could be euthyroid. If things go low, that's hypothyroidism. If things go high, that's hyperthyroidism. But things can go low and then they can go too low. Things can go high and then they can go too high. So if we're talking about thyroid, hypothyroidism is hypothyroidism. But the dangerously low part of that's going to be myxedema coma. So the dangerous part is myxedema. And I didn't actually write it this way last week, so this may help to just kind of visually see it this way. So the dangerous part of hypothyroid is myxedema. Then you have hypothyroid, then you have euthyroid. Then you have hyperthyroid, and then the dangerous part of that is going to be thyroid storm. Okay? Now, Becca, so that's thyroid. That's probably that's not every single thing, but that's the most important things that you need to be able to recognize, especially in a question. Okay? Sometimes they'll give you the lab values. It's less likely that they'll give you like thyroid lab values because those aren't ones that most people are taught at this level. But they will give you symptoms. They'll describe a patient. All right, so Becca, let's go. You ready?
I'll attempt it.
Let's go. You got this. So, all right, so Becca, we have a patient with, all right, so you've got a patient that has, oh yeah, these are the exact notes from last week. All right, so you have a patient with, they've lost a lot of weight, they're running a fever, they have diarrhea, things like that. What is something that you are likely to suspect? Because if they just have increased heart rate with symptoms, that just means they're sick. But if they have increased heart rate, increased blood pressure, increased temperature, if they're sweating, what kinds of things might you think there? Well, you could think of it could be some kind of drug overdose. It could be some kind of sympathomimetic agent that's causing activation of your sympathetic nervous system. It could also be thyroid. In this case, is it likely to be hyper or hypothyroid?
Hypo.
If everything's ramped up?
Oh, no, hyper, sorry.
It's going to be hyperthyroid. In hyperthyroid, tell me about your T3, T4 compared to your TSH.
So in hyper, the T3, T4 is low and TSH is high, right?
All right, it's the opposite way. So the lab value that we're always kind of looking at is T3, T4. In hyper, T3, T4 is up. In hypo, T3, T4 is down. So the number one lab value that we're looking at is the free T3, T4 level. And then the TSH is going to have the opposite effect. So in hyper, tell me again, in hyper, which way does the T3, T4 go?
It's elevated.
Okay. Therefore, the TSH is going to be?
Low.
Low. Okay. All right. Who gets hyperthyroidism? Who are some people who have this or who are predisposed to have this?
Females over the age of 40.
Okay. Now that's for any autoimmune condition, whether we're talking, whether we're talking Graves' disease, myasthenia gravis, lupus, systemic lupus erythematosus, any of these autoimmune conditions, the kind of epidemiology of who gets it is primarily females greater than 40. That's for all these conditions. But other things so what kind of autoimmune condition
Like
would lead
Hashimoto.
Hashimoto is for hypothyroid. So let's go back over that.
You have Hashimoto's over on hyper side.
So I have Hashimoto on the hypo side.
Oh, okay.
Okay. So everything over here is on the low side. Oh, okay. I see what you mean compared to this line.
Yes.
So I probably should flip flop those. Okay. So
okay.
Yeah, I probably should redraw it and flip flop that for you, but I'll have you do that. On the low side, on hypothyroid, your T3, T4 are going to be low. Your TSH is going to be high. Some things that cause hypothyroidism or Hashimoto. So hypo, Hashimoto. Okay. So hypo and Hashimoto, they go together. If they've had their thyroid removed, now they can't make as much thyroid, or they can't make any if they've had the whole thyroid removed. So of course their thyroid is going to be low. It may have been removed due to a goiter. It may have been removed due to maybe they had radiation before. Maybe they had lung cancer from smoking and they had to get radiation to their throat and that damaged their thyroid. That could have caused it. In hypo, everything is low. Okay? Mm-hmm. The dangerous form of this is what's called myxedema coma. Okay, so myxedema, I have it on the low side right here. Mm-hmm. It's the most severe or the most life-threatening form of a low thyroid. Let's talk about the high. In the high side, so I'm over here, in hyperthyroidism, your T3 and T4 are going to be elevated. Your TSH is going to be low. Some causes of hyperthyroidism are going to be Graves' disease, which is another autoimmune situation, just an opposite effect.
Right.
Different drugs or medications, but everything is going to be ramped up in hyper. Because think about it, they're hyperactive, okay? Right. The most severe form of hyperthyroidism is thyroid storm. This is where everything is dangerously high, okay? And this dangerously high heart rate can send them into a tachydysrhythmia. This dangerously high blood pressure can send them into a stroke, a heart attack, hypertensive crisis, things like that. The drug of choice to treat thyroid storm is a beta blocker. The number one beta blocker that we use, if it's available, is propranolol, okay?
So Brian asks, is a thyroid storm the same thing as a thyroid crisis? And I'm also curious about that.
Yes. So those are just different terms for the same kind of thing. Okay. Thyroid storm, thyroid crisis. Yes. That would be the same situation.
Awesome.
Okay. Now, how do you feel about that? You think you can give me that again?
Yeah, absolutely.
Okay.
It'll be something that I have to write and redraw so that way I can pull it back up in my mind.
Okay. See what you can do just by talking to me.
So hypothyroidism is when your T3, T4 is low. Hashimoto's is one of them that go with it. It is an autoimmune disorder. So it goes with your women that are over 40 are most likely for your autoimmune disorders. So everything is low. With hyperthyroidism, that is Graves' disease. Everything is elevated, your heart rate, your blood pressure, putting you at risk for stroke and other heart-related issues. And it is when your T3, T4 is elevated and your TSH is low.
Okay. Okay. All right. So here, let's do it this way. Let's just redraw it and we're going to do it right now. So as your thyroid starts to go low, okay, so now you're in the hypo, okay, And then when it gets dangerously low,
It's myxedema coma.
so really low. All right, so let's just call that hypo, and then we'll call the other one really low. Okay. So what's the dangerously low thyroid called again?
Myxedema coma.
Okay, so that's going to be myxedema coma. Think about it. When you're in a coma, everything's low, right? You're kind of like passed out. Okay. Then you have hypothyroidism. Now, hypothyroidism, tell me again. So give me some situations for hypothyroid.
Hashimoto's.
Okay. So it could be caused by Hashimoto. That's an autoimmune condition. Okay.
Right.
What else could cause it? What else could make your thyroid not work as well?
If they've had surgery.
Okay. So if you've had, so when it comes to surgery, you could either have part of it taken out or all of it taken out. So that's going to be, let's say if you have half of it taken out, that's a hemithyroidectomy. Hemi meaning half. Thyroid is thyroid. Ectomy meaning to remove. So when you remove half of it, that's a hemithyroidectomy. Or if you remove all of it, that's a total thyroidectomy. So that's surgery. Okay, cool. What else? What else could make it underactive? Okay, it could be that you have a goiter. So a goiter is where it's enlarged, but because it's enlarged, it's affecting the function of it. Okay, so it's not working normally. Right. So a goiter can go either way with it being hypo or hyper. A goiter can cause both. Another cause would be an iodine deficiency. All right, let's tie something in. If somebody is allergic to iodine, what antidysrhythmic should they not have?
Oh, is it lidocaine?
It's not lidocaine.
No, it's amiodarone.
It's amiodarone, okay? Because in amiodarone, let's watch this. Amiodarone. So,
right.
So amiodarone has kind of this IOD in it. Mm-hmm. Okay. So
that's what I'm trying to think of. So
okay, right. So in amiodarone, that's where we would probably, if they have an iodine allergy, we would not give them amiodarone. Okay.
Right.
Okay. So those, now tell me about your lab values in hypo. T3, T4 are going to be?
I don't remember what you said the lab values were.
Okay. I mean, but is it going to be up or down for hypo?
Oh, it's up for hypo.
So in hypo, you have a decreased T3, T4, and increased TSH. Mm-hmm. Okay. What kind of symptoms are they going to have? If it's hypo, that means low. So everything is low. Everything like what?
So they'll have elevated weight or weight gain.
Okay. So I don't want you to say it as elevated, only because I want you to think of everything being low. So we're going to say it a different way. So let's start with heart rate, decreased heart rate. So we would call that bradycardia. Okay. Decreased blood pressure. We would call that what? Hypotension. Okay. Decreased respiratory rate. We would call that?
Bradypnea.
Okay, cool. Bradypnea.
Is that how you say that?
It is. That is. Bradypnea, yes. Okay. Decrease GI motility. We would call that constipation.
Okay.
And then decrease metabolism. That's how I want you to say it. Decrease metabolism. And that's going to be weight gain. Weight gain. Okay? Does that make sense?
Yes.
Then you can have what's called a normal thyroid. And the word for that is euthyroid. Okay? Now let's go to the high side. So as things start getting higher, so now we have hyperthyroidism. Okay? In hyperthyroid, how are our T3, T4 going to be?
It's elevated.
So we're going to have elevated T3, T4. We're going to have a decreased what?
TSH.
Okay, TSH stands for thyroid stimulating hormone.
Okay.
Okay, so decreased thyroid stimulating hormone. Now, in this situation, because it's hyper, everything is elevated.
Right.
Okay.
So elevated heart rate, meaning tachycardia.
All right, so they're going to be tachycardic. Okay, so elevated blood pressure or elevated, elevated BP, hypertension. Okay, elevated respiratory rate, tachypnea. Okay, elevated GI motility,
which could be diarrhea, or
that's going to probably lead to diarrhea. Okay, elevated metabolism,
which is weight loss.
that's going to be weight loss. Elevated temperature, fever.
Yes.
Okay, or they're febrile. And on the other side, I should put.
So with hypo, wouldn't they also be just cold?
Yes. So in hypo, they have a decreased temperature, so they have what's called cold intolerance. Okay. Does it help to kind of visualize it like this?
It absolutely does. Which you said previously that our minds pull up pictures and not words, which mine absolutely does. So to
everybody's does.
It's something I can recall later on when I'm sitting and I'm like, oh crap, what was that? Okay, let's picture what he drew out. Now let's make those lists going down.
Okay. Now, but I'm not having to just memorize bullet points. What I'm having to think about is, okay, it's either normal, it's low, or it's dangerously low. It's normal, it's high, or it's dangerously high. Okay. Now let's talk about the hyperthyroid, where everything is high. What causes that? What are some causes of hyperthyroid? Say it again.
Graves' disease.
Graves' disease. That's another autoimmune condition. So notice that both of these, so Hashimoto and Graves, they're both autoimmune conditions. They're just on different sides of the coin. Okay.
Right.
All right. What else could cause it? Well,
medication.
Say it again. Okay. Certain medications or certain, let's say, illicit drugs. Okay. What else? And these are big ones to know. Now, you could also have a goiter here, but especially what's called a toxic goiter or toxic multinodular goiter. Okay, what is that? So if this is the thyroid gland, okay, the thyroid should just be kind of a smooth surface. However, in a goiter, it gets bigger. So let's make the thyroid bigger. So let's okay, a goiter is where the thyroid is now bigger. That's just a goiter. However, when you have nodules in it, that's called a nodular goiter. Okay? But if these nodules are now, like the nodules may just be sitting there, not causing any problems, it's just a nodular goiter. However, if these nodules are actually causing the thyroid to secrete too much thyroid, then we call it toxic. So then it's a toxic goiter. Okay? So in hyperthyroid, a toxic goiter could be the cause. Now let's go to the worst case of this. And this is where it's dangerously high. Whoa, sorry. Where it's dangerously high. And what do we call that situation?
I don't remember.
That's going to be your thyroid storm.
Oh, yeah.
Okay. So now, instead of it just being elevated heart rate or tachyarrhythmia, it's like dangerously high heart rate, dangerously high blood pressure. So just think about it. Everything is being dangerously high. So we're on the danger side. Okay. What's our big treatment here?
To lower everything.
Okay. So think about it. What could I do to lower, what could I give to lower heart rate? What could I give to lower blood pressure?
Beta blockers?
Yeah. What could I do to do both of those? That would be a beta blocker. So I'm not having to memorize it. I just say, okay, it's too high. What could I give? What do I have in my toolbox that can lower heart rate, that can lower blood pressure? Okay. So for both of those, that's going to be a beta blocker. And what's the number one beta blocker?
Propranolol.
Propranolol. Propranolol. Okay. Now, does that make sense?
Yes.
That's thyroid. Okay. Now, we could do this exact same kind of thing for, let's say, adrenal emergencies. But in the interest of time, what I want you to do is I want you to go back to the video where I covered it, because I talked about Cushing's, I talked about Addison's disease. I actually drew out the adrenal gland. I talked about the different hormones that get made in the different parts in the adrenal medulla versus the adrenal cortex. Who was here last week that remembers this? Does anybody remember from last week? What hormones or what is the middle section of the adrenal called? So you've got the outside and then you have the inside. What is the inside of the adrenal gland called? Type that in the chat for me. Okay. All right. So that's going to be the, anybody know? Okay. So that's going to be the adrenal medulla. And then the outside, that's going to be the adrenal cortex. Now, I did do a whole video on this last week. So just go back to it. In fact, let's see if I have, yeah, because these are the notes from last week. So, oh, you're not seeing what I'm doing. So yeah, this is what I drew last week. So go back over this. I also uploaded this exact document with my notes. That's uploaded under last week's video. Now let's review something really quickly though.